All right, good morning, everyone. I have the pleasure of introducing Dr. Michael Ling today to give us grand rounds. He actually trained here at ECU in the Internal Medicine and Psychiatric Residency Department, and we were fortunate enough to keep him on as faculty in both Internal Medicine and the Psychiatric Department. He is integral in the education of the residents in both Internal Medicine, the Med Psych residency, as well as the Psychiatric residency. He is beyond the doubt always helpful for the residents and always there for the residents and giving advice and just lending a helping hand, as well as he's given multiple presentations on the overlap between medicine, internal medicine, as well as psychiatric, so he's definitely well qualified to give us the talk today. So please welcome him to give us the discussion on cost-effective options in the treatment of insomnia. Thank you.
Thanks, everyone. Good morning. So let me get started. Okay. So let me give you a little bit of background on what the NC Accept project is. This is basically an academic liaison between the 4 major medical schools to reach out to primary care physicians, and I'll give you some of the background as to why in the next couple of slides. But what they asked North Carolina, Duke, Wake Forest, and ECU to do is look at 4 major topics that have been troubling the state of North Carolina from a evidence-based and cost-effective method as far as some of the prescribing patterns that primary care docs were doing. So what wound up happening is each school took a topic and they developed an educational program to reach out to primary care physicians to not only educate them on more cost-effective ways to prescribe medications in the psychiatric realm, but to give you an evidence-based background of why you should prescribe in that manner. So our objectives for this talk, which do come to us from Wake Forest, will be to describe the role of insomnia as a risk factor for psychiatric illness, to discuss the impact of insomnia on the course of psychiatric illness, and to propose a variety of cost-effective yet evidence-based strategies for managing insomnia. Okay? No disclosures obviously to be made for this program. It received no commercial support. So if you look at antipsychotics, traditionally we have used these, starting with Thorazine back in the 1950s, primarily for psychotic illness, schizophrenia, bipolar disorder, etc. And that was primarily when we had Thorazine and Haldol, which only worked on dopamine. However, as new agents have come out with a variety of receptor targets, the use of antipsychotics has branched out in many realms. Tics, for example, refractory hiccups, for example, as well as insomnia. And if you look at the prescribing patterns from 1991 going up to 2005, you can see that the all others category has been gradually increasing. Now this was the slide that got the state of North Carolina's attention, and I'm sure some of you have seen this, and for the benefit of those who have not, I'll go through it. Looking at the year 2010, these were the top 15 medications that were written in the state of North Carolina for Medicaid alone, okay? And if you look at the top 15, 8 of them are psychiatric, okay? And number 1 and number 2 are Abilify and Seroquel, okay? It costs about $1 to $2 million a day for Medicaid to pay for those drugs per year, okay? Now, that is not necessarily what got the state of North Carolina's attention the most. What they realized when they looked through the prescribing data and the notes that they were reviewing was that the overwhelming majority of those top 2, the Abilify was written for depression and that the Seroquel was written for sleep. Also, the overwhelming vast majority of both of those were not written by psychiatrists. They were written by family practice docs and internists. And since the data to support the use of Abilify in depression, which is another talk entirely, and for Seroquel in sleep is virtually non-existent, the state realized that something had to be done about that. So this is the background for why we're having this talk today. This is also another interesting look at this, and I highlight this for the residents to show you that drug representatives can be very smart people. Okay, if you look at the Seroquel data, this is the breakdown of that big graph just before, you'll find that there are a variety of doses that are written for, everything from 50 to 300, okay? And if you add up the 50, the 100, and the 200, that adds up to a whole lot of money. And I will tell you that there is absolutely no use in psychotic illness for anything below 300 milligrams per day, okay? However, a drug representative will tell you this. The drug representative who brings you Seroquel will say there's absolutely no use for Seroquel in sleep. But then they will leave you 50, 100, and 200 milligram samples to use in your clinic, okay? This is an example of very cost-effective and strategic advertising for your drug without advertising for your drug. Okay, so looking at some of the psychiatric background, the most common cause of chronic insomnia would be? Any guesses?
Work.
Very true. Sleep. All right. It's actually psychiatric illness. If you look at the American Journal of Psychiatry epidemiological data from 1994, not quite 45% of them are going to have a primary psychiatric diagnosis. Now, medical disorders are there, as well as obstructive sleep apnea, of course, okay? You do have to screen for those. But overwhelmingly, folks who are going to come in are going to have an underlying psych diagnosis, especially if they've had insomnia greater than 2 weeks, okay? So unresolved insomnia is going to rapidly increase the odds of a new psychiatric disorder. And this matters to you guys because pound for pound, you're going to treat way more depression and anxiety than I ever will. Okay, that's just from a volume basis. I'm going to get the worst, you're going to get the most, especially for major depression and panic disorder. Now, different people will disagree on whether the insomnia makes it worse or sets it up in the first place. And what I tend to tell people is insomnia is going to prime the pump. Okay, if you have a little bit of a problem and then you're not sleeping, you are ergo then going to have a major problem. All right. And what we see is looking at people over the course of a year, that is the case, all right? If they have treated insomnia at 1 year of follow-up, their odds of any psychiatric disorder is about 12%. Psychiatric illnesses are relapsing and remitting, okay? That is by their very definition. However, if you don't treat their sleep, it increases by a factor of 3, all right? And for anxiety disorders, it can increase by a factor of 4. Anxious people who don't sleep get way more anxious, and then they come back to you for more benzodiazepines. All right? So, psychiatric correlates of insomnia, it is an independent contributor towards poor quality of life. And that is if you control for any and all other symptoms of major depressive disorder. It is also a contributor for morbidity and mortality. Studies have shown if you get less than 5 hours of sleep consistently per night, your odds of getting in a fatal motor vehicle accident increase by a factor of 3. And that makes perfect sense, okay? It is also highly predictive of suicide in many studies. Outside of alcohol, which is present 50% of the time, the presence of insomnia is usually noted in a completed, i.e. successful suicide. So you want people going to sleep. The most common residual symptom in an otherwise successfully treated patient is, 3 guesses, this is an insomnia talk. Okay. Insomnia it is. If you look at threshold, i.e. they're successfully treated versus subthreshold, you'll notice that sleep has the most common leftover residual symptom. So other than fatigue and loss of libido, they're still going to come back to you saying that they're not sleeping. So what I want people to realize is you do need to write hypnotics. I have given this talk in a couple of community settings and they go, well, I'll just leave this all alone and I will refer everyone to you. That is not going to be very cost effective either. You do need to think about giving them sedatives along with antidepressants if they come in depressed or anxious. You just need to think about which ones are going to work the best and be the most cost effective. Okay? Complications of residual insomnia after treatment of depression include 3 guesses, we've talked about this just a second ago, an increased rate of relapse, okay? So let's say they come in with a persistent insomnia, even in the case of a psychiatric disorder. There are several things that you're gonna need to think about and rule out when you're evaluating them to try to figure out what you're gonna write. A, is there an incomplete response? You know, I often tell people when they refer folks to me for depression and anxiety, you picked the right option usually when they come to me, but the dose is usually low. I'll get a referral for, you know, refractory depression and they're on 25 milligrams of Zoloft a day. And all I do is double the dose and see them back in 6 weeks. do not be afraid to titrate these doses. I usually tell internists or family practice docs, pick 3 antidepressants, get to know them well, and don't be afraid to titrate them to the max dose. You don't need to know all 60 on the market. Just pick 3 and get comfortable with them. Iatrogenesis is also a common factor. I have seen primary care docs, pediatricians give people Wellbutrin at bedtime. Wellbutrin is exquisitely energizing. So they take Wellbutrin at bedtime and it's like they've taken 6 cups of coffee and now they're walking the floors. All you have to do is move that to the morning, problem solved. So make sure you know what time of day they're taking it, how often they're taking it. Cups of coffee as well. I've had people come to the clinic for refractory insomnia, and one gentleman about a month ago drank 3 cups of coffee at bedtime because coffee doesn't affect him, because unlike everyone else in the world, caffeine doesn't have any impact on him. Then he would wake up at 2 a.m. and what would he do but drink 2 more cups of coffee before trying to go back to bed? And he wanted a sedative. That is not the best treatment option for that particular patient. Medical disorders, obstructive sleep apnea, chronic arthritis do need to be evaluated for and stabilized. A primary sleep disorder can also be looked for and evaluated. And poor sleep habits. You know, as we teach our medical students, sleep hygiene, sleep hygiene, sleep hygiene. We all have patients who basically the only time they get up off the couch is for the 1 out of 3 visits they come to us in the primary care clinic. You know, increased physical activity during the course of the day is going to help sleep at night. So an ancillary assessment of insomnia, and I'll go through each of these rather quickly so we can then get to the drugs and discuss them in more detail. Sleep logs are beneficial, especially if you have a poor historian, and we all know what that is like in the clinic, okay? They'll just tell you, I can't sleep, and you can't get any more data out of them than that. There are about 50 or so sleep logs on the internet. All you need to do when you're looking at a sleep log is make sure that it is user-friendly. You just want to get an idea of their sleep patterns, and most sleep logs will help you document what they're doing before they go to bed, what time they're going to bed, and what time they're waking up. So you can get a sense of what exactly is going on to correct the sleep hygiene before you go any farther. So the tip for sleep logs, user-friendly, make sure you give it to them. Blood work, for the most part, is not going to help you much. Insomnia is an H&P diagnosis. You have to sit down and interview your patient and do a good physical exam. If you find something positive, they've got degenerative arthritis, for example, or they've got an increased neck circumference, then you chase it down. The one exception to this rule, especially if you get a history of restless leg syndrome, and residents keep this in mind for your boards, iron deficiency anemia is a classic cause of restless legs. So you would want to order a serum ferritin. You will see that question on your boards. I'm pretty confident. Otherwise, if you don't have a history and physical to point to a blood test, it's probably not going to be very useful. Again, the vast majority of these are going to be psychiatric, and there's no blood test for psych issues, unfortunately. Sleep studies, again, if you're going to send someone for a sleep study, you need to have a history and physical to guide you in that direction. What I often tell folks before you call your sleep doctor is do an Epworth Sleeping Scale score. If the score is greater than 10, they should probably head over to pulmonary. If the score is less than 10, then it's still your job to figure out what the etiology is. So the Epworth score, and you can print that off the internet as well, it's a 1-page test, about 10 questions, takes them about a minute to fill it out, and then you can put that in your referral, and then your sleep doctor knows that you know what you're talking about before you make the referral. Non-pharmacological treatments of insomnia. And here is my evidence-based nod toward therapists. What I also tell all of my primary care docs is, know one therapist in your community, know that person well, and refer to them. Well, we had Miriam Godwin at one point, and that was a great referral source for us. But wherever you go in your career, you need to find one because they will help you out a lot with issues such as this, okay? Pound for pound, cognitive behavioral therapy is as effective as a drug for most psychiatric illnesses, if not all of them. And I'll show you a study to prove that. This came out in JAMA in 1999, and it's comparing cognitive behavioral therapy versus Restoril, 30 milligrams in primary insomnia in elderly people. And what they did is they had them record a sleep diary and a sleep study. So you have an objective and a subjective measure of how they're sleeping. And they did this 2 weeks pre-treatment, And then they did this 6 weeks into treatment for a total of an 8-week treatment course. So 2 weeks pre, 6 weeks into, all right? And then they followed how they did. CBT alone, pharmacotherapy, together, and then just placebo. And as you can see from pre-treatment to post-treatment, CBT was better, okay? It was better than the drug. And if you did them both together, they combined, it was even more superior, okay? And CBT has the advantage of not having any side effects. You don't have to worry about falls. You don't have to worry about refills. And it is more enduring because the things that they learn in CBT, they will take forward, as opposed to when they stop the Restoril, you have the same problem again, okay? So pick a therapist, learn them well, refer to them often. It will serve you when you get out into the community. So now let's talk about the drugs, okay? You have some that are on label, and then you have some that are off label. And on and off is basically a matter of whether the drug company wanted to put in the $30 million necessary to get FDA approval. So I say this with, you know, a wink and a nod, but this is kind of where we're at as far as the FDA is concerned right now. So the first thing I'll talk about are the benzos, and we'll use Clonazepam as a classic example for this, okay? This was done by Lundberg et al. In 2000, and he looked at 80 depressed patients who were on a drug. They were on Prozac. And then they were given Klonopin 0.5 to 1 at bedtime for about 21 days. And what he found on the Hamilton Depression Scale was that they did better for those 3 weeks. However, he then followed it up, okay? And he took 50 of those depressed patients from the initial group and he followed them for 18 weeks. And what he found was you only get good bang for your buck for the first month. After about 21 days, they return to placebo, okay? And that will make a lot of sense. How many of you have written a benzodiazepine and then you get a call not too long later going, this was nice, but now it doesn't quite work as well as it used to. Can you bump the dose, okay? That's the classic scenario with both benzos and narcotics. And that's what typically will happen in this case. And this was a lot of his data to show that. You know, initially you'll see a separation, but even at 20 or 40 milligrams of fluoxetine, they come back to the same level. So what we often tell people is if you're gonna use a benzodiazepine, do it at the beginning, get them off of it, okay? You either get them off of it and switch to something else, or you hope that the Prozac or the Zoloft or whatever you're using gets them through on its own, okay? Pros and cons of benzodiazepines. Some are FDA approved for sleep. Clonazepam actually is not. Prosom, Dalmane, Serax, and Restoril are the only FDA approved ones, although people kind of write for them as a group. They are, relatively speaking, inexpensive, okay? However, the cons are numerous. You have tolerance issues, you have dependence issues, you have daytime sleepiness issues, especially if you use a long-acting benzodiazepine. Falls, behavioral disinhibition, especially in the elderly, problematic. Probably not the best option for treating chronic insomnia. Now you do have Ambien, and Ambien has been studied as an add-on for depression, okay? Looking at 190 patients already on an antidepressant, had persistent insomnia, were randomized to 10 of Ambien or placebo, and they followed their well-being, their subjective improvement in sleep, and their improvement in depression, because you remember I told you if you treat the sleep, the mood will get better. So we wanted to track that as well. And what they found was definitely by week 4, you did have separation. It actually started by week 2, because Ambien is a fast-acting drug. I mean, you're going to notice it the first night when you take an Ambien. And their Hamilton depression scores significantly separated, all right? Pros, it is FDA indicated for sleep, only for the short term, however. Ambien has only ever been approved by the FDA for up to 6 weeks, and that is it, okay? However, you'll see people on Ambien 2-3 years, and if you try to take them off of it, it's like you sacrificed a toe. It is useful in depressed patients, as you can see, and it is relatively inexpensive. Anyone have a relative idea if you wrote Ambien for a self-pay patient, how much they'd have to cough up at the pharmacy for a 10 milligram Ambien tablet? This is Walgreens data that I'm about to quote, so it depends on your pharmacy, but it's about 40 to 45 bucks. It's not the worst thing you're gonna get. It's been getting a lot cheaper over the course of the last year and a half as it's gone generic. If you do Ambien CR, you're looking at 230. Okay, and that's why you always get those prior authorizations when you write for Ambien CR. And they also will only give you 15. And the reason for that is it's not supposed to be used chronically. Short-term use only, it is a controlled substance, and you can have hallucinations and cognitive problems. There are studies in the psychiatric literature of sleep driving on Ambien. So you need to let them know they can dissociate if they take this drug. There was actually a very successful lawsuit that was won in Charlotte. A woman was taking Ambien and she got in her car and she drove and she ran into a tree, and her argument was that the doctor didn't tell her she could sleep drive, and she won. So make sure you warn them about dissociation if you're going to write Ambien and document it in your note. Now, they also did the exact same study with Lunesta, the butterfly drug, okay? Same sort of deal. They got Lunesta and Prozac versus placebo and Prozac. And as you can see, they separated out on their Hamilton depression scales from 4 to 8. And then folks criticized this study and they said, I don't think this is legit because 3 of the items in the Hamilton depression rating relate to sleep. I don't think you changed their mood any, you just helped them sleep better, and you artificially fudged your data as a result. So they went back and they repeated it. And when they gave people the Hamilton score this time, they just took out the sleep items. And again, you can see that it separates, okay? Even if you take the sleep questionnaires out, their mood got better. And anybody who's ever been post-call walking around here irritable after being here overnight will know, if you don't sleep overnight, life is tough.
They don't do that anymore.
Of course. This is for the folks back in the day who can remember what I'm talking about. Back in the Stone Ages when we did overnight call. Pros and cons of Lunesta. It is FDA approved long term. Lunesta is the only agent that got approved FDA for long-term use of sleep up to 18 months. So you have open-ended use. You have positive studies in depressed and anxious patients. Cons, it is still controlled. You do have tolerance and dependence. Once again, if you were going to write this for a self-pay patient, Lunesta 1 milligram at bedtime for a 30-day supply, how much would you pay if you went to Walgreens? It's not $45. It's $200. $200 or $197 plus tax. Okay? So Lunesta is not a cheap drug. Keep that in mind when you're writing it. And for the most part, Medicaid is going to tell you you have to fail 2 or 3 primary drugs and demonstrate persistent insomnia before they'll approve it. Another reason why you get those prior authorizations in the mail. Roserum is a melatonin agonist. It's one of the newest ones on the block. There aren't a whole lot of studies supporting it now as an adjunct yet. We haven't done the placebo and Prozac studies for Roserum yet. Roserum does have some advantages, however. It does not have any issues with cardio or pulmonary depression. So if you've got an elderly person who's had a cabbage, who's got COPD, Roserum's not going to bother it, okay? The problem with Roserum is it's going to take it about 2 to 3 weeks to work because it is a melatonin sensitizer. So you're going to wait 3 weeks or maybe a month before you're going to see a firm effect. So it has started falling out of favor as a result of this. The other major con for Roserum is it is expensive. You're looking at about $245 if you write this for a month. And add that to the fact that you got to wait 3 weeks for it to work. People are tending to coming back to clinic going, I don't really want this, give me Clonazepam. Okay, looking at tricyclic antidepressants. Okay, there is a new drug on the market, just to make you aware of it. It's called Salinor, all right? And all Salinor is 3 or 6 milligrams of Doxepin. The same Doxepin that you can write for $4 at Walmart at 10 milligrams a day, all right? Tricyclics are potent sedatives. Back before Prozac and Zoloft were on the market, this is what psychiatrists wrote, all right? And the beautiful thing about tricyclics are they are great sleep maintenance drugs. Sleep maintenance drugs are a lot of times what the internist needs because the medical problems that you're managing, the arthritis, the kidney disease, the liver disease, whatever the case may be, lead to frequent awakenings. So you want to learn sleep maintenance drugs, not necessarily sleep onset drugs. Doxepin is a great sleep maintenance drug. As you can see, it tends to keep people asleep, if you're looking at the top of the graph, because this is the number of frequent awakenings. You tend to level out quite nicely. It takes a while to get them to sleep, and that's because the dose is low. It's 3 and 6 milligrams. but you can maintain them quite well. And at anywhere from 6 to 10 milligrams a day, the anticholinergic side effects are minimal. You're not going to give someone urinary retention on 10 milligrams of doxepin. I have written it up to 150, and I've still had people tolerate it. You just have to go up really slow to let them acclimate. Okay? Pros and cons of doxepin. It's FDA approved for sleep, great for sleep maintenance. It's not controlled. You can use it for as long as you want, years if need be, and it's inexpensive as the generic, down to 10 milligrams a day. 10, 25, and 50 you can get at Walmart for $4, all right? Sleep onset, it's not going to be the greatest issue. It's not yet studied as an add-on to SSRIs. You do learn in medical school you can't mix a tricyclic and an SSRI, you'll get serotonin syndrome. That's a little bit overblown. If you keep the doses low, you're not going to have that kind of an issue. You just have to keep the doses low. And it's very expensive as Salinar at 3 and 6 milligrams. You're looking at about $90 to $100. So I have a very hard time justifying $90 at 6 milligrams, $4 at 10. There's not that much of a clinical difference of 4 milligrams of doxepin. So what I tell people pretty much is to ignore Salinar, and hopefully it will go away. Okay. Now we're going to talk about Seroquel, also known as Quetiapine. And this was a study done up at the University of Pittsburgh, which is a huge sleep research center. And they have their own scale, the Pittsburgh Sleep Quality Scale, that they use in this study. And these are folks who got either, and I apologize for the reproduction, Prozac and placebo are on the left side. Prozac and Seroquel are on the right side, okay? And when you look at the Pittsburgh Sleep Quality Index, as a general rule, the lower the score, the better you're sleeping, okay? So if you look at this, at the beginning, you start to see some separation. Quetiapine is really good at the beginning. By week 2, you've gone from 1.49 with placebo to 0.94. However, as you keep tracking down to week 8, they're the same, okay? So, you know, it's 0.8 to 0.6. And that is one of the major points that the University of Pittsburgh wanted to get out to people, is that just like Clonazepam, you're going to get the best bang for your buck in the first 2 weeks, okay? And if you add Quetiapine, you're going to have lots of interesting pesky side effects, most notably weight gain, okay? I have seen 50 pounds on Seroquel. It makes people eat like crazy, and that is just because it targets histamine and muscarinic receptors, all right? Because of its histaminergic effects, that is how you get a lot of your sleep from Seroquel, all right? Seroquel is glorified Benadryl when you're using it as a sedative, especially at low doses, okay? So you're gonna get tolerance to it quickly. Does anyone have an idea how much 50 milligrams of Seroquel per night for 30 days costs? $385. That's how much you would get for 1 month of Seroquel at 50 milligrams. That's charged out of your pocket, okay? You can also get akathisia, which is an overwhelming generalized sense of restlessness where people are incapable of sitting down to sleep or eat because they're so restless. People kill themselves because of akathisia, okay? Considering that you are going to lose all of your clinical efficacy probably by week 6, if not week 8, it costs $385. It is probably not the most cost-effective and evidence-based treatment for insomnia. Okay, again, I will point you to that. So, pros and cons of Quetiapine. Several studies show a very good sleep benefit in depressed patients initially. It is not a controlled substance, that is true. It's also not FDA indicated for sleep. You have huge metabolic effects. If you're an endocrinologist, if you're an internist, you are not the biggest fan of Seroquel because it is very diabetogenic, all right? Akathisia is possible even at low doses, and it is extremely expensive. Now, Trazodone is a much better option, all right? Trazodone is often used as an add-on for many of our antidepressants. If I've got someone on Zoloft 50 or Prozac 20, which are traditionally energizing antidepressants and they're not sleeping, Trazodone is a marvelous drug to add at about 50 to 100 milligrams at bedtime, okay? It helps with self-reported sleep and your perception of sleep. So a beautiful thing about Trazodone is you give it to someone at bedtime, they wake up the following morning, they feel like they've slept. And Wake Forest looked at this, and this data is about to be published. It's still in press. And they looked at alertness, memory, and motor stamina. And what they found was if you give this drug, all three of them get better, all right? Because folks slept deeply, they slept at onset, and they slept through the night. All right, what I will often do is I'll write 100, because you can get a hangover effect from Trazodone, and I tell them to break it in half first. Try the 50. If the 50 doesn't cut it, go on and take the 100. That way they've got some flexibility. But Trazodone is marvelous. Okay, very effective for insomnia, not controlled, may improve alertness, $4 at Walmart. Okay, there's about 30 years worth of randomized controlled data supporting Trazodone for use in sleep, both individually and as an add-on, okay? It's not FDA approved. There are at times adverse memory effects because you can get a hangover effect if you write it, especially over 150. Just to let you know, you can write Trazodone up to 600 if you are inclined, all right? It is not necessarily a low-dose drug. You must mention priapism. It's unlikely at low doses, but it can happen. I had a patient that I was treating over in ID clinic, actually, who's been on Trazodone 3 times in his life on individual episodes. And the first time he had no problems with it and he was doing well and he stopped it. The second time he never had any problems with it, doing well and he stopped it. I give it to him the third time at 50 milligrams at bedtime. He's in the ED with urology getting decompression of his penis. I'm like, sometimes things just happen. But you have to warn them each time. Priapism is a risk, even at low doses, however unlikely, on Trazodone. Remeron is a sedating antidepressant. It is a marvelously effective sedating antidepressant, okay? It improves self-reported sleep in an open trial, and it is a monotherapy agent. So you don't have to give someone Prozac and Ambien. You can just give them Remeron. The lower the dose of Remeron, the better it makes them sleep. The higher the dose of Remeron, the better an antidepressant it is. So for an internist, 15 to 30 milligrams is your range. You're going to get the best bang for your buck for both at that dose. Okay, pros, it's effective for sleep, it's not controlled, it's inexpensive, about $35 a month. Okay, weight gain is possible. Just like Seroquel, Remeron makes people sleep and it makes people eat. So given our population, you have to pick your patient carefully if you're going to give them Remeron. Okay, the last topic that I'll discuss, which may be of interest to everyone, is the use of gabapentin for sleep, not only as a general insomnia agent, but for insomnia specifically in alcoholics. And this is some data that's been coming out that's very exciting from the psychiatric world. They looked at using gabapentin as a sleep agent, and they decided to focus on a subset of people who were alcohol dependent. And what they found is not only did they sleep better, but they tended to crave alcohol less. And if you remember, Neurontin has GABAergic type activity. So people tend to have less cravings when they're on Neurontin. So they started getting this data and they go, well, let's chase this down. And so then they started randomizing people, abstinent alcoholics, to either 300 twice a day of Neurontin or 600 at bedtime. And what they found was the desire to drink now, the difficulty to control their drinking, the strength of their cravings all went down compared to placebo while on the drug. So then they did some further studies and they found that how long can you maintain abstinence? So if you go up to high dose gabapentin, 1500 milligrams divided over the course of the day, look at the time to their first heavy drinking day. Placebo starts trailing off fast, as you would expect. But gabapentin, even going out to 100 days, that's a pretty good length of time for an alcoholic to remain abstinent. So what psychiatry is starting to look at is, could we have now a pharmacological cocktail for alcoholism? Give them Revia, providing their LFTs are okay, 50 milligrams a day. Okay, even with the Combine trial out in 2002, we have tons of randomized controlled data that Revia is hands down right now the best pharmacological drug for treatment of alcoholism. Give them Revia during the day, give them Neurontin at bedtime. And you may just keep them from returning to drinking. You just got to follow their LFTs. The other beautiful thing about Neurontin is it's not going to mess with their liver because a lot of these folks have hepatitis to begin with. Neurontin is passed through the kidneys unchanged. So you're not going to affect hepatitis with Neurontin. You will with Revia. So very exciting data in the psychiatric world for alcoholism. Pros and cons: helpful for sleep, may curb alcoholic cravings, it's not controlled. Relatively speaking, it's inexpensive. Gabapentin has been going generic over the last couple of years. Right now, I don't even have a con to give you from Neurontin other than the fact that it is still relatively expensive at about 70 to 80 bucks a month. Not too terribly bad depending upon how you dose it. So in summary, an H&P is always where you start with insomnia patients. Other than the common cold and back pain and headaches, it's arguably the most common minor complaint you're going to get in a primary care clinic. So you need to know how to evaluate it and how to manage it. Manage unreasonable sleep expectations. You'll have plenty of people who come in, if I don't get my 12 hours of sleep a day, I haven't slept. That makes no sense, okay? Consider zolpidem, trazodone, doxepin, mirtazapine, and gabapentin, opposed to some of the others that I mentioned. And then gabapentin definitely is emerging, if you have an alcoholic, as your preferred agent. What questions do you have?